Hello and welcome, everyone. My name is Kristen Talbot. I'm the program manager for MAVEN Project. Thank you all for joining us today and our friends at HealthPoint for hosting today's session, Successful Management of Gout in the Primary Care Setting with Dr. Robert Goldfien. Dr. Goldfien worked as a rheumatologist at Kaiser Permanente for over 28 years. In addition to his clinical practice, he held roles as Chief of Medicine at Kaiser Richmond, Chief of Rheumatology for Kaiser East Bay, and Chair of Rheumatology for the Permanente Medical Group. And we're just so very lucky to have him as one of our MAVEN Project volunteers. So with that, I will turn it over to you.
Okay, thank you. And thanks everyone for joining the talk. So the title suggests that this is something I think people can manage in primary care, and so I'm always happy to talk about this subject. And it is something I've had a particular interest in during my time as a rheumatologist. I'm trying to advance the slide.
All right, if you go hover over the left bottom corner, an arrow should maybe appear. There you go.
Oh, okay. All right. So I have no disclosures, and this was the accreditation in information that Kristen just gave you. So learning objectives, when we're done talking today, I will have talked a little bit about increasing prevalence and risk factors for gout, how to think about gout as a chronic metabolic disorder, and also distinguishing the treatment of acute gout attacks from the management of chronic gout and hyperuricemia. Finally, I'm going to show you some slides that illustrate kind of a protocolized and organized target-oriented approach to managing serum uric acid that you can actually use in your clinic. So what is gout? Gout is a chronic condition, and the underlying metabolic disorder is hyperuricemia, and this leads to accumulation of crystals of sodium urate in the joints and other soft tissues. It almost always will come to you typically presenting as an acute and self-limited form of monoarthritis, which we usually call a gout flare. It is commonly seen in the first metatarsophalangeal joint, the big toe, but also can be seen in the midfoot, ankle, and sometimes other joints. It's common in gout for the frequency and duration of gout flares to increase gradually over time as crystals of uric acid accumulate in the joints. And in more severe cases, you can actually see tophi under the skin in elbows and hands and feet and other places. So gout is the most common inflammatory arthritis in men, and it's much more common in men than women, unlike things like rheumatoid arthritis or lupus, which are much more common in women. It does increase in incidence with age, and the incidence varies somewhat worldwide. It's higher in the US and some Asian populations, for example. Interestingly, the incidence of gout has increased a lot in the last 30 years. This is all over the gout literature. And it will be understandable if you look at the comorbidities in gout. And about 75% of gout patients have hypertension, 30% or so have diabetes, and another 30% have chronic kidney disease, stage 3 or more. These comorbidities have been seen in many studies, and they're pretty consistent. It's not an accident, however. The things that cause hypertension and the treatments for hypertension, the disorders in diabetes and kidney disease are things that tend to raise uric acid levels. And so as those things have increased a lot in incidence in the past 30 years, so has the incidence of gout. Before I talk about treating gout, I also want to talk about diet and gout. When someone comes into your office with gout, one of the subjects that almost always comes up is diet. And this is because the common understanding and belief about gout is that it's caused by eating the wrong things, particularly seafood, organ meats, drinking alcohol. People aren't necessarily aware that high fructose corn syrup also can increase uric acid. And interestingly, legumes are often listed on the list of foods that can cause uric acid to go up, but they've never really been shown to increase gout flares. Okay, so I think the thing I'm going to focus on, and I want to just mention here, is that diet is always topmost in people's minds, patients' minds, because I think it's something they can see and they're aware of, and they have this idea that they can control it by using dietary measures. But it isn't really the cause of gout. It's better to think of diet as a trigger for gout in people who already have hyperuricemia and uric acid crystals in their joints. Um, and Notably, dietary intervention typically has a limited effect on serum uric acid. It's, if someone comes in with a uric acid of 9 and they go on a sort of a gout diet, the uric acid might go down to 8.5, but it's probably not going to go down low enough to be useful. So it's okay to support people's ideas about diet and have good dietary habits, but it's usually not enough by itself to treat gout. Gout is identifiable by finding sodium urate crystals in the joints, but it's not always practical, and so it's often a clinical diagnosis. And that clinical diagnosis is based on having a high serum uric acid. It's conceivable to check a serum uric acid and have it be normal, but it's almost always high in untreated gout. A note about what it means for the uric acid to be high is probably appropriate. In labs, the normal, quote, normal level of uric acid is often said to be as high as above 7.2, for example, is often an upper limit of normal. So if you do a uric acid test on a patient and the lab says it's normal, but it's 7.2, that's not inconsistent with gout. It's normal from a statistical point of view, but not a physiologic point of view. Some labs have corrected this in my experience and now say above 6 is compatible with gout. So it's almost always above 6 in untreated patients. Clinically, you look for the typical acute episodic pattern, or sometimes you can see tophi in a long-standing case, and the typical joints involved. But it is an episodic arthritis. The symptoms go away completely in between episodes. It's not more usually waxing and waning unless it's sort of well-established late involvement. What is the role of radiographs, ultrasound and CT? Well, radiographs will often show typical characteristics of gout in patients who have had it for a long time. We don't need to go into what those findings are, but your radiologist would know. Ultrasound and CT are not routinely used to diagnose gout, but I thought I'd just note that there are ultrasound findings that are typical for gout. And there's a type of CT called dual energy CT, which will actually show uric acid crystals and deposits in the tissues. But I wouldn't rely on them. They're not generally available for everybody. Family history is worth checking into because gout is often hereditary, especially when you see it in younger patients. It's common that they'll have a family history of it. Presumably, this is due to mutations and things like urate transport molecules, so that excretion of uric acid is less efficient. Now, if you do see a typical picture, I just want to say it's, probably it makes sense to treat that as gout and then worry about the workup afterwards, because people are generally in a lot of pain. I think I mentioned before, gout's rare in people with the uric acid less than 6.5, but uric acid will fluctuate over time. Treating acute gouty arthritis, there are a couple of tips I think that can be helpful. One axiom I use is treat early and aggressively. I tell my patients as soon as they feel that toe start to tingle or some kind of change or new symptom to start on treatment right away. The sooner you start treatment, the more quickly you can get rid of the gout attack. Options for treatment, as you presumably know, are NSAIDs, colchicine, oral steroids, and I put ICE in capitals. I guess that's a bad abbreviation these days, but ICE has actually been shown to help reduce symptoms in gout. Treatment options are limited sometimes by comorbidities. As I pointed out before, a lot of patients with gout have chronic kidney disease or diabetes, and that may limit your treatment options. Another thing to pay attention to is if you don't treat until the symptoms are completely gone or almost completely gone, the symptoms have a tendency to recur and flare up again. And that's one way people can get sort of this recurrent or recalcitrant gout attacks. Also, frequent or persistent symptoms may require longer treatment, just until the symptoms are gone. NSAIDs for acute gout. Indomethacin has been the traditional NSAID used, but it really doesn't have to be. Other NSAIDs can work perfectly well. In fact, ibuprofen is something I use a lot. It's a relatively fast-acting NSAID. The main thing is to use them in equivalent doses. So in ibuprofen, you might use 600 or 800 milligrams 2 to 3 times a day to start with, and then you can taper it. And as I just noted, shorter acting NSAIDs may have a more rapid effect, but any NSAID will work. Prednisone for acute gout. Oral prednisone is very effective for gout. It's not usually the first line treatment, although it might be in someone with CKD or who can't tolerate NSAIDs, or more commonly, if someone's treated with NSAIDs or colchicine and it's not effective, you can put them on prednisone. I usually start with about 40 milligrams daily, and I'll treat for 3 to 4 days and then taper over, a 10-day period, more or less. And that usually works. Intra-articular steroids can be used, but I don't use them for small joints. If it's a knee or something, you could do that. Colchicine is a traditional treatment for gout. Interestingly enough, colchicine was only approved by the FDA for treatment of gout in 2010. It's part of their program to sort of grandfather in or ungrandfather in old treatments. When I trained, it was commonplace to recommend colchicine 0.6 milligrams once an hour until one of two things happened, until either the gout was completely controlled or until there was uncontrollable diarrhea. And unfortunately, the latter usually ended up being the case. And so that treatment is sort of out of favor. The FDA, when they approved this drug, they also put out recommendations for dosing of colchicine. What we usually tell people now is to take 2 tablets of 0.6 milligrams at the onset of symptoms, followed by 1 tablet an hour later. And then you can use 0.6 milligrams twice a day for 2 to 3 days after that, or longer if you need to, and there's no other contraindication. I mentioned the old regimen. I do avoid colchicine in patients with CKD stage 4 or more. Colchicine in those patients can build up to high levels and have severe toxicity. So lower doses in patients with milder chronic kidney disease can be effective and probably okay to do. So that's the treatment of an acute gout attack. Each patient will be a little bit different, but between those various options, you can generally find something that will work. But I want to move on now to something which I think is a little bit less often talked about, but I think is really key to managing gout. And that is how to manage recurrent gout and hyperuricemia. I like to think of gout as a chronic metabolic disease dressed up as arthritis. And I'll get into a little bit more about what that means, but the implication of being a chronic metabolic disease is that management requires a systematic target-directed approach and a long-term treatment. And that treatment is urate-lowering medication and monitoring of serum uric acid. The analogy, to my mind, that's the best for understanding this is thinking about hyperlipidemia. And this is an analogy I tell my patients about commonly because it's much more understandable to them. And the point I make is that when we treat coronary artery disease or coronary heart disease, the primary treatment of it is, for many people at least, is cholesterol-lowering medicines, statins. And we don't use statins because hyperlipidemia has any direct symptoms. Nobody has symptoms of hyperlipidemia. clearly we use statins to prevent heart attacks. And so we give people statins long term, and what happens is they don't have a heart attack. It's exactly analogous to giving someone uric acid lowering medicines. And what it prevents is not a heart attack, but a gout attack. And gout attacks aren't as serious as heart attacks, but they are pretty painful. And so the goal is to keep the uric acid low. And of all the chronic conditions that we treat, this is as simple as any of them, and it actually is essentially curable. It's a curative treatment. People who are on urate lowering treatment long enough essentially don't have any more uric acid in their joints, and they don't get gout attacks anymore. So treatment of hyperuricemia in a target-directed, persistent, and consistent way is the key to managing gout. And that's what I want to spend the rest of the talk sort of going over with you. So in general, the way to manage gout is to keep the uric acid level below 6. 6 is approximately the uric acid concentration at which crystals form. And if you keep it below that, then you stop the accumulation of crystals in the joints and you start to allow your body to flush out the crystals that are there. Urate lowering therapy is effective in almost all patients in achieving that target if they're used properly and monitored. And this is an important point because over the years, the most common thing I saw in my gout patients who came to me as a rheumatologist was that many of them had been on treatment, but they hadn't had their treatment titrated to a proper dose, or they hadn't stayed on the treatment, and therefore it was ineffective. So when I say it's effective in almost all patients, I'll show you some data that supports that, but that's only if it's used appropriately, and that's what we're going to talk about. Interestingly enough, and probably one of the worst problems with dealing with managing gout is that when you start someone on uric acid lowering treatments, they can actually have more gout flares. I just attribute this to fluctuations inside the joint, the crystals and the fluid in the joint getting sort of perturbed by the changing levels in the blood, and that triggers gout attacks. So the way we deal with that in treating hyperuricemia is we use what we call flare prophylaxis. And that's typically colchicine. It can be NSAIDs, but the idea is that if you start someone on uric acid lowering treatment, you can also start them on a small dose of daily colchicine. And that acts a little bit like pouring water on a smoldering flame. It sort of keeps it from flaring up during that period of time when your body's getting rid of the uric acid. It's also important when you do this, when you start patients on urate lowering treatment, that if possible, explain to them that they're going to get some flares after starting treatment, or they very well might get flares. And getting a flare after starting on treatment doesn't mean the treatment's not working. It just means it takes a while for the body to get used to the new level of uric acid. So it's important to warn people that they may get a flare. And when they get a flare, it's also very common for people to stop their allopurinol or their urate lowering treatment. So what I tell them is don't stop your allopurinol if you get a flare. Just treat the gout attack the way you normally do. Medication non-adherence in gout is very common. This has actually been studied, and it's more common to see non-adherence in gout than with other chronic conditions. What does that mean? Well, it means that patients need to be educated to stay on their medicine, and it means that periodic monitoring of serum uric acid is necessary to make sure they're still taking it. And I'll get back to how that's done. The other general principle I use is even though probably the majority of people with gout are under excretors of uric acid as opposed to overproducers, we now use allopurinol as the first line treatment for essentially all patients with gout unless there's a contraindication. And I mentioned here HLA-B 5801, which I will digress and talk for a minute about allopurinol hypersensitivity syndrome. This has always been kind of the concern or the worry that doctors have about using allopurinol, because we know that the small percentage of patients on allopurinol can develop a severe hypersensitivity syndrome. And this we call, it's either something like Stevens-Johnson, or sometimes we call it DRESS syndrome, which is a drug reaction with eosinophilia and systemic symptoms. These are severe and potentially fatal reactions with rash, fever, organ system disease. And it only occurs in about 0.3 in 1,000 patients. Usually it's in the first several months of treatment. Um, and we now know that it's primarily a concern in people with this HLA gene called HLA-B5801. I don't think we know the exact mechanism of this. But what you do have to know is that there are certain populations that have higher levels or higher frequencies of B5801. In this country, it's primarily Chinese, Korean, or Thai ancestry. Maybe a small increased prevalence in African Americans, but not as much as these other ethnicities or ancestries.
Dr. Goldfien, we have two questions.
Yes.
First, once the urate crystals have been cleared, can Lab 5801 be tested from the joints? Can the allopurinol be stopped?
Ah, um, say the thing about HLA-5801 again.
Can HLIB 5801 be tested from the joints, and can the allopurinol be stopped? Big words.
So first, the HLA-B5801. So this is a serum marker. This is a serum test. And you can actually order it just like any other test, HLA-B5801, just like you'd order an HLA-B27 for ankylosing spondylitis. So it's a serum test you do, and you want to do that before you start the treatment. I'm sorry I didn't say that clearly, but HLA-B5801 is something to test before you start someone on allopurinol. And it's recommended currently that you check in the people listed in my bullet point here, the Han Chinese, Korean, and Thai ancestry. That recommendation might change. It's possible that in the future there'll be guidelines to check it in more populations. But for the moment, my practice is if I have someone who's in one of these categories, I check this before I give them allopurinol, and it's a simple blood test. As for the allopurinol, staying on allopurinol, the way I explain it to my patients is that if so you could treat someone with allopurinol for, let's say, 3 years, and at that point they haven't had a gout attack for 2 years, and you could reasonably conclude there are very few, if any, crystals left in the joints. I think in principle you could stop the allopurinol at that point, but my expectation is that they would eventually build up the gout crystals again, and then start getting gout attacks. So what I tell my patients is it's like treating hypertension. If you go take a treatment for hypertension, your blood pressure comes down. If you stop that medicine, the blood pressure will go back up again. So even though I think of it as being curative in a sense, it's not in the sense that the treatment's typically limited in time. We usually will continue it long term. I hope that answers the question.
I think so. Thank you. We have a couple more. Do you want to wait to the end, or do you want to answer them now?
It's okay. Go ahead.
Okay. Diet, you said, does not make much difference if I heard correctly. During flare, should the foods on the list be strictly avoided?
So maybe I might have oversimplified this a little bit. I do think that diet matters because their dietary things can trigger attacks. So if someone has attacks that are triggered by eating, let's say, seafood, and you put them on allopurinol, let's say, and their uric acid comes down, if they eat a bunch of seafood and they have a lot of crystals still in their joints, they still probably could get a gout attack. When I say it's not the main issue, it's mainly in causing chronic hyperuricemia. So early on in the treatment, I usually do tell people be cautious about their diet, but I don't tell people they can't eat anything. If someone has a small piece of meat once a week, I don't think it's going to cause them to have problems with their gout. So, so I don't think the diet in itself will normalize uric acid in most people, but until the treatment's been in place for quite a while, it still could trigger gout attacks.
And then the last question for right now, how often do you monitor uric acid after one, first starting uric acid lowering treatment, two, while still uncontrolled and adjusting doses, and three, when controlled?
Yeah, that's a great question. That question I will answer in a couple of minutes because I'm going to actually go through that in detail when I show you my sort of protocol for doing this. But
Okay,
that's something we should talk about. Yes.
thank you.
Um, so just to finish with the B5801, I screen this before I start patients on allopurinol if they fit in one of these ethnic categories or backgrounds. Um, And that's just a precaution. You know, starting someone on urate lowering treatment is appropriate for most gout patients, but it's not an emergency. So you have time to check this before you start the treatment. You can avoid the issue with B5801 by starting people on febuxostat, which is a much newer drug. Um, I don't tend to do that because last time I looked, febuxostat was still on patent and very expensive, and it doesn't work any better than allopurinol. So I reserve that for people who can't take allopurinol occasionally with side effects or if they're B5801 positive. But that would be the choice to use for those patients. Finally, it's still a good idea to let people know if they start allopurinol to just to be alert for any itching or rash or fever if they notice any of that, that stop the medicine right away and contact me or their primary care doctor. So these are a little more specific recommendations. Um, we tend to recommend starting people on a low dose of allopurinol. And usually it's 100 milligrams per day. If someone has chronic kidney disease, you could start at 50. Um, and my habit is to treat them with that dose for two weeks, maybe 3 weeks, and then have them go up by 100 milligrams. And then at that point, think about starting to monitor the serum uric acid. Um, there's no perfect protocol for doing this, but the basic idea is to titrate the dose up gradually and monitor as you go. And you want to titrate the dose of allopurinol to where you achieve a serum uric acid of less than 6. Um, the reason for titrating slow is partly just I like to do that anyway because a lot of medicines will have fewer side effects at lower doses, so you don't hit them all at once with a big dose. The second thing is you want them to be on the lowest dose that controls them. And so you don't necessarily even have to get everyone up to 300 milligrams. And finally, if the level of uric acid is readjusting more gradually, it's probably less likely to trigger a gout attack. So for those reasons, we usually start low and titrate. And if it's febuxostat you're using, also called Uloric, that's the brand name for that. It has a standard dosing at 40 or 60 milligrams. So I start with 40. When I start urate lowering treatment, I generally recommend the daily colchicine. As I said, it's not mandatory, but studies definitely show that it reduces the risk of gout flares, which can complicate the first phase of treatment. So one tablet of 0.6 milligrams per day is typically what I recommend for people, and I'll have them do that for up to 6 months or longer if necessary, but not permanent. Finally, some people are going to have gout flares, and you do have to treat them, but the main thing is to make sure that the patient doesn't stop their urate lowering treatment, the allopurinol. They don't need to stop that. If they stop and start that, it causes more fluctuations in the uric acid level and tends to produce more flares. Okay. So I'd like to spend the next few minutes showing you some data from it was really a kind of a study I did when I was at Kaiser. I was working in the primary care department and we had developed some disease management programs for patients with diabetes and hyperlipidemia, hypertension that used nurses and extended roles primarily and pharmacists to help manage these chronic conditions. I had the idea that this could be done for gout. And so what I did is I set up a protocol, which is what's shown here. That's why it's called the Gout Pharmacist Management Program, because I worked with a pharmacist to do this. And the protocol is diagrammed here. And I told the primary care doctors they could refer their gout patients to my gout management clinic, and we would try to manage it for them. At the top, you can see it says current gout flare, yes or no. So if someone was having a gout flare, I just wanted to include on the side there that we would treat that gout flare just like I talked about a moment ago. But the next step was to start or titrate urate lowering treatment. In our case, I used, for most people, 100 milligrams of allopurinol. Then after 2 to 3 weeks, we would have them come in and check their serum uric acid level. And one of two things would happen. Either they would be at goal and you'd continue down on the protocol, or they weren't at goal, which was usually the case, in which case we would go back and titrate the urate lowering treatment and then check it again in 2 to 3 weeks. And we would repeat that cycle until the uric acid level was below 6. At that point, I would wait 3 months and check their uric acid level again. And if they were at goal at that point, they would be discharged from our clinic back to primary care. So the question about when to check the uric acid level is generally after 2 weeks on a particular treatment, usually the uric acid level will be settled at its new level and stable, and that's a good time to check it because by then you can know if you need to increase your dose. The idea of checking it at 3 months was really mainly determined by the fact that a lot of people they will stop their treatment. And what happened with this, and I'll show you some data that demonstrates this, is a certain number of people will get to goal, and when we check them 3 months later, they wouldn't be at goal anymore. I would say 9 out of 10 times that was because they stopped taking their medicine, which I mentioned before was very common. So in the protocol, we routinely checked the uric acid again in 3 months and kept doing that until they were discharged from clinic. Once somebody's at goal and it seems like they're stably taking their medicine, I would say that you could check the serum uric acid again in 6 months and maybe once a year after that. The main thing is that they stay on their treatment. So to answer your question, it depends on how confident you are that they're on their treatment, but the longer they've been on it, the less often you have to check it. My experience with allopurinol is very much the same as my experience was with statins. You almost never see someone on a statin whose cholesterol doesn't go down. And that's pretty much true with allopurinol. If their uric acid goes up again, you pretty much can assume the most likely thing is they stop their treatment. Okay, so this slide shows what happened to the uric acid level in the people that we treated in this clinic, which was close to 100 people. Now, the clinic was meant to last just for 12 months. So if someone wasn't at goal at 12 months, we didn't keep them in the clinic, though we didn't try to stop them. We didn't stop trying to treat them. What this shows is if you look at the red bars, those are the uric acid levels for each patient entering the clinic. And then correspondingly, down below, the blue bars matched up with each red bar was the uric acid at the time they were discharged from the clinic or it ended. And I think it's sort of obvious graphically that the great majority of these people were able to achieve a uric acid level of less than 6 using this protocol. It was, I think, something like 85% of them were at target using this protocol. So the approach is highly effective. And it wasn't very time intensive using a pharmacist. It's just, I don't think most people have access to that as something to help them. But this is something you can do in your clinic. This was just a graphic way of describing what happened with individual patients. And I think I have it here because I think it's instructive. If you look over on the left-hand side at the time when uric acid lowering treatment was started, you'll see that pretty much every patient had a uric acid level that went down. Some of them went all the way down to below 6, but most of them went partway down. Then you see an interesting thing. You see a lot of them go back up again. And this, I believe, is reflecting what I mentioned before, which is that, people start their medicine, they take it for a while, and then they run out of it or stop it. And what happens is their uric acid level comes back up again. So if you then continue to check it, and then you get people back on their medicine, the majority of them ended up being at goal. Not everyone, but the majority of them. So this kind of pattern is common in gout patients. They stop their medicine, they start it, they stop it, they start it. And the trick is to convince them somehow to stay on it long term. The purpose of this slide is to give you an idea of what to expect in terms of dosing. And what this shows is these are not percentages, but these are just absolute numbers of patients in the clinic who achieved a uric acid target of less than 6 on a particular dose of allopurinol. So on the dose of 100 milligrams on the left, there was a very small number of patients who reached goal. It was either 1 or 2 patients. By the time you get up to 300, approximately 2/3 of the patients were at goal on a dose of 300 milligrams or less. And then it took more than 300 milligrams in the remainder of the patients. The highest dose I had used in this clinic was 600. And I would add here that the FDA has approved allopurinol in doses up to 800 milligrams. So it's almost never the case that you need 800, but it's safe to use a higher dose than 300. So the thing about this that's important is that it's been a habit for many people over the years, many doctors, to treat gout by just putting somebody on 300 milligrams of allopurinol and then assuming that they were on the appropriate treatment. And what this shows is that that's going to work about 2/3 of the time, but not all the time. And this finding of about 65, 70% effectiveness of this dose has been seen in other trials that are in the literature. So I think this is representative of what you can expect. So if you're at 300 and the patient isn't at goal, you can increase the dose to 400. Sometimes I have someone take 1.5 tablets and it's 450. But I rarely have to go higher than that. And the main thing to keep in mind is just like in diabetes, you set a target and you treat until you get to that target. Okay. So that protocol is, theoretically, you could print that out and use it as a guide to treat your patients, but it doesn't have to be viewed rigidly. The basic idea is start low, titrate up, check uric acid, and when you get to the right uric acid level, continue that dose. I'd like to conclude just by looking at a couple of, I think, very typical gout cases and talk a little bit about sort of how to approach them and what to do. This case, recurrent gout flares, it's a typical patient. It's a 47-year-old Chinese male. He's had 3 gout flares in the past year, which is more than he'd had before, although he'd had it for a number of years. He'd been told to avoid certain foods and to take colchicine when gout flares occur. He'd had an elevated serum uric acid of 8.2 about 2 years ago, but it had not been checked since that time. His past history was notable for diabetes and hypertension. He was actually on low-dose aspirin, which can raise uric acid levels. On exam, he has a tender, swollen left red and red left midfoot, not his toe, but the midfoot, which is a common place. And the question is, what do you do for this patient? These are the potential answers that I put out there for us. And more than one of these turns out to be correct. So just let's go through them. First, start colchicine, 0.6 milligrams in the protocol I outlined above, 2 times an hour apart, then 1 BID for 3 days, or start indomethacin, 50 milligrams TID for 2 to 3 days and taper it. B, tell him to stop his aspirin. C, start him on allopurinol, 300 milligrams per day. D, have him get a serum uric acid level, a serum creatinine, and an HLA-B5801 gene testing. And E, tell him to eliminate red meat from his diet. So these are all options for the treatment. And I'm going to just now go through what I consider the best answers for this based on what I've said up till now. A, start colchicine. Yes, he's got a gout flare. You have to treat that gout flare. And starting colchicine is a perfectly good way to do it. Indomethacin is another thing you could do. If he's had luck using one of these regimens before and it's worked for him, I would generally recommend the one that he's familiar with and has worked for him. But it's definitely appropriate to treat this gout flare. So you tell him to stop his aspirin. That's probably not a wrong answer in a sense, but I tend to think that the aspirin's going to play a relatively minor role. Once he's on appropriate treatment, the aspirin won't prevent him from getting to goal. And if he's on it for a good reason for his heart disease, I don't know if it's still a good reason this year, but it used to be, then it's okay for him to stay on that. And I don't tell people to stop. C, start him on allopurinol 300 milligrams per day. Well, number one, I tend to recommend a lower dose, the 100 milligrams to start with. But more importantly, if you go to D, since he's Chinese, he's at higher risk for allopurinol hypersensitivity reaction. So rather than rush into a uric acid lowering treatment, treat the gout attack and check the HLA-B5801 gene test. It should be available from the standard clinical labs. It's something, if you want, you can check and see if it's possible to order it, but it should be. And that shouldn't take more than a week to get that result back, at which point, if it's negative, you don't have to worry about the allopurinol. If it's positive, you can start him on febuxostat. Finally, do you tell him to eliminate red meat from his diet? I sort of alluded to this earlier. I don't tend to tell people they can't eat any red meat or any shellfish or have any alcohol. I think modest amounts of any of those things are consistent with effective treatment. So those are my answers for that. The second case is what I'm calling refractory gout. So as a rheumatologist, one of the situations I come across is people have gout and they've been having recurrent or persistent flares for several weeks. They get a flare, they go on treatment, it gets better, but then it comes back the next week and comes back again. And at that point, their doctor's given up and asked me to help. So this is a guy who comes in with 2 recent gout flares affecting his ankles, first the left and the right. He's been on allopurinol 300 milligrams daily for about a year, but he had stopped it a few months ago. And then when this flare happened, he's restarted the allopurinol. Again, a common scenario. He took indomethacin with the recent gout flare, but he's still having ankle pain. His PMH is notable for CKD3 and hypertension. On exam, he has a tender and red and swollen right midfoot and ankle. And 6 months ago, he had his uric acid checked. It was 5.7. So what do you recommend now? Do you stop the indomethacin and start oral prednisone with a taper? Do you stop the allopurinol? Do you continue the allopurinol and start daily colchicine after the prednisone is completed? Do you increase the allopurinol dose to 400 milligrams per day? Educate the patient that he needs to continue allopurinol long-term to eliminate gout flares, and repeat the SUA, the serum uric acid, in 3 weeks. My answer is it's probably reasonable to stop the indomethacin and start prednisone. He's had 2 recent flares. It came back after indomethacin. He's still having some symptoms on the indomethacin. So I probably would stop that and tell him to take prednisone. It's, my experience with this situation is that prednisone is pretty safe in this scenario, being used for a week or 10 days. Stop allopurinol? No, you don't want to stop allopurinol. Now that he's back on it, stopping it again will just cause the uric acid to fluctuate more. So the next answer, continue allopurinol and start daily colchicine after the prednisone is completed. That's what I would recommend. Going on the colchicine, which he wasn't on before, will reduce the risk of getting more gout attacks when he stays on his urea lowering treatment. increase allopurinol dose to 400 milligrams per day. I said no because he had his uric acid checked a few months ago and it was 5.7. My interpretation of that is that 300 milligrams of allopurinol was enough of a dose to get him to target, and he just needs to stay on that dose. Doesn't need to be increased. Educate the patient that he needs to continue allopurinol long-term to eliminate gout flares. Yes, patients need to hear this sometimes a few times before it really sinks in, that they can't stop the medicine just because they haven't had a gout flare for a few weeks. And then I do repeat the uric acid level just to make sure that he is at target again. All right. So that's the end of my presentation. I hope that you will come away from this with a little more confidence in treating gout, and understanding sort of how to focus on effective treatment for acute gout, but also more importantly on management of hyperuricemia, which can be done in a relatively straightforward way, much like the other chronic conditions you treat.
Dr. Goldfien, we have a couple of questions.
Okay.
Someone who wants you to discuss some diuretics, specifically hydrochlorothiazide triggering gout flares potentially.
Sure. So yes, hydrochlorothiazide, thiazide diuretics, and Lasix do affect uric acid levels, and can raise them. And unlike aspirin, I I frequently will tell people to find another antihypertensive to take if they can. There are options with hypertension for most patients, so thiazides are not always necessary. And if there's a good option for a patient, yes, that is something that can lower the uric acid level a little bit. By the way, losartan actually lowers uric acid a little bit. So that's something to keep in mind too.
Great. Are colchicine and allopurinol dose adjusted for CKD? I know you mentioned part of this earlier.
I'm sorry, what CKD and allopurinol dosing?
Yes, dose adjusted.
Yes, that's a really good question. It's been sort of the belief over a period of many years that chronic kidney disease, i.e. CKD 3 or 4, increases the risk of hypersensitivity reactions to allopurinol. I think the current understanding of that is that it may somewhat, but it's not dose related. And so I think it's okay, and it may be necessary to use typical allopurinol doses for patients with chronic kidney disease. I have two other brief comments about that. One is that, as I mentioned before, if someone's got CKD 4 or more, I would start with a lower dose of allopurinol, maybe 50 milligrams. That's relatively standard. But you can titrate it. And more importantly, and point two is that if you have someone who comes in with chronic kidney disease and they've got a uric acid of 11, and you put them on 100 milligrams of allopurinol because you're worried about the dose, it won't fix the problem. Their uric acid will go down from 11 to 10, but probably not to 6. So it's been, I think, the habit of nephrologists over the years to just put people on very small doses of allopurinol, but I think it's fruitless because what it does is it doesn't fix the hyperuricemia. And again, there isn't really good data that the dosage of allopurinol affects the risk of hypersensitivity reactions. So the answer is start lower, but it's okay to titrate the dose up until you get to target.
Great. Any recommendations on when you do make recommendations regarding the amount of seafood when you're making dietary recommendations? Any specific number of ounces?
I don't tend to do that. The closest I will get to that is, I mean, I tell people, yes, a little bit of meat once or twice a week is fine. Just don't go out and have a big, 2-pound prime rib. And that's sort of a gross way of addressing that question. But I let people know that moderation is probably okay. Likewise with alcohol, I tell people, if you have 6 beers a week and you have one once a day, that's probably fine. But if you have 6 beers on Saturday, you might have trouble because that's a big dose all at once, and it'll cause more fluctuation. So moderation is more important than exact numbers.
When you do use an intra-articular steroid, do you have a preference?
I almost always use Kenalog. You can use Depomedrol, methylprednisolone, but I usually use Kenalog. And if it's a knee, I use 40 milligrams of Kenalog. It's a pretty standard dose for knee arthritis of other kinds also.
And then any issues with insurance coverage regarding testing for the HLA-B 5801?
I have not run into that. We didn't have that issue at Kaiser. But actually, I've done a lot more of those tests in the last few years where I've been working at a couple of local federally qualified health centers. And I will say one thing, I do think it might require a certain diagnosis code in some cases. One of my colleagues where I work said she had a little trouble ordering it because when she tried to associate it with the diagnosis of gout, it wouldn't go through. And we figured out that you could find some diagnosis. It was something like, monitoring for medication treatment or some kind of weird code like that that allowed her to order the test. But I haven't run into that myself.
And then I think we have one more question. Any thoughts regarding the relationship of hyperuricemia to cardiovascular disease?
Another good question. Um, I can tell you what I think we know. And this is something I read a lot about when I was doing my projects on gout. There's been a question for many, many years, is hyperuricemia lead to problems, cardiac disease and renal disease primarily, because there are correlations between hyperuricemia and renal disease and heart disease, but were they correlations or causation? I think, having looked at a lot of data and read about this, it's not clear that hyperuricemia by itself increases the risk of heart disease. It's more likely that they're covariants. There is probably data that having a gout attack increases the risk of heart attack in the short run. In other words, in a close time sequence, if you have a bad gout attack, that your immediate risk of a heart attack is higher. I think there's some data to that effect. But the data on hyperuricemia has never convincingly showed that it's an independent risk factor for cardiac disease.
Great, thank you so much.
Okay, well, any other questions?
We'll pause a minute and wait for any last minute. Sheila, yes, is my question, is my answer. Just saw that, sorry. Just a reminder, if you have, nope, not if you have, if you want CME credit for this session, that the survey is going to appear in a tab on your browser when you close out of this webinar. But if you miss it, no problem. It'll appear in an email tomorrow, 24 hours from now. Email from Zoom. So wait for that Zoom email. And just a reminder, if you have any questions after this session, I often do that. You can always submit an e-consult to Dr. Goldfien or any of our MAVEN Project volunteers using the community portal. And if you have any questions with that, you're always welcome to email me and we can sort out any challenges.
Looks like, I'm sorry, we have one more. Just
please.
anything to do for nothing to do for asymptomatic hyperuricemia, someone asked.
Generally, the recommendations there's never been a strong, clear recommendation to treat asymptomatic hyperuricemia. There might be some exceptions to that. People with renal failure and very high uric acid, I think sometimes they worry about urate nephrosis as a complication. Also, if someone has nephrolithiasis, there's a connection between nephrolithiasis and hyperuricemia in some patients. That might be a reason to do it. But asymptomatic hyperuricemia, mostly I would just say, you don't need to treat it.
Great, thank you so much.
Well, have a great day, everyone. And Dr. Goldfien, thank you so much. This was fantastic.
Okay, thanks.